Gabriela Rosa is a renowned fertility specialist, a best-selling author, Harvard University awarded scholar, researcher, and educator. She's also the founder of the Rosa Institute, an organization dedicated to helping couples create healthy babies. And on top of everything else, this woman's really busy. She's also the podcast host of Talk Sex with Gabriela Rosa. Hi, Gabriela.
Hi, Tara. So nice to see you. Thank you for having me.
Likewise. Thanks for being here. I'm excited to talk to you all about sex, reproductive health, and fertility.
Absolutely. I think that we have a lot to cover. That's for sure.
All right. Well, I've asked some of my followers to send me questions. And the first question I have for you is, how is sexual pleasure related to reproductive health and fertility? And like the little context is maybe people don't think about reproductive health and fertility in relations to pleasure at all, right? Because people get so stressed out when they're trying to conceive, or on the other side, like people that are so afraid of having babies, like getting pregnant accidentally, and cannot have sexual pleasure. So what is this intertwined relationship between sexual pleasure and reproductive health?
I think that is such a great question. And if I was just to answer it, as a short answer, it would be they have nothing to do with each other, because in my clinical experience over the last 20 years, if I was to go by what I observe, that's what I would have observed, is that sexual pleasure is such a foreign concept for most couples trying to get pregnant. It's almost like, what you said is exactly true, is that we spend our entire teenage years being told, if you have sex, you're going to get pregnant. And if you get pregnant, it's going to ruin your life in all sorts of ways. And so, really, and it really is, that is the messaging, that we receive. It's like, it's wrong. It's not something that you want. If you have, teen pregnancy, I mean, what girl or woman alive today has not received the message of teen pregnancy is bad? Right. Or if you get pregnant, it's going to ruin your life at that stage in your life, right? And so I know that for me personally, that was pretty much the messaging that I had my entire life. So it was almost like, I was diagnosed with polycystic ovarian syndrome at the age of 18, and the doctor literally on the telephone called to get my results, and he literally says to me, you have polycystic ovarian disease and you're likely never to have children. Oh. And in that, yeah, I know, right? It's like, oh, thanks, that's wonderful bedside manner. But other than that, I was taken aback, and I was like, wow, okay. At 18, I was still very much brainwashed by if you get pregnant, it's going to ruin your life. So I was kind of not really thinking, and I had career goals and aspirations and objectives that I wanted to see unfold in my life. And so it wasn't something that I've really focused on at that time in my life, thinking, this is going to be the worst possible thing, because I've always dreamt of being a mother. But at the same time, it was really something that I had to consider, and I pondered on, what does this mean? What does this mean for my future and my life? And, do I want to have children, and all of these things? So I think that for most women, when it comes to sexual pleasure, because of this conditioning that we have societally and culturally, we do have almost to put ourselves in a position, in a situation, that we start to think about pleasure in a different way. Because when it comes to fertility, one of the things that often happens in my experience and in my observations with patients is that immediately upon deciding that you want to be pregnant, there is a timeline situation that goes on that unfolds in front of a woman that is like, okay, this is it. I need to figure out when I'm ovulating. We have to have sex 1 to 2 days before that. And this is how it goes. And, there's all of these preparatory processes that go on that we need to almost be ready for. And we get our partners to be ready in a certain way and to do certain things. And so that, when it comes to the day in which, ideally prior to ovulation, because if you're going to have sex on the day of ovulation, you are going to miss the chance of being pregnant. Like from a technical perspective, you want to be having intercourse from 1 to 2 days before ovulation. And we can talk about timing in a moment. But you can see that all of a sudden, the mindset has shifted. The mindset around sex has shifted from, I'm doing this because it's enjoyable and pleasurable and I want to get off, to, I need to figure out when I need to have sex so that I can actually get the egg and the sperm to meet at the particular time and day of the month that they need to, so that I can have a baby. So it's almost like there is this massive shift in our entire sexual identity, from really wanting to experience to being very process driven and focused around reproductive function. So when it comes to pleasure and reproduction, no wonder there is such a disconnect for most people, especially when they're having difficulty conceiving. Typically in my clinic, I'm treating patients who have been, experiencing infertility and recurrent miscarriage for over 2 years. Wow. And so what happens is that for many and most of those people, they are in a situation where they feel disheartened, they feel hopeless, they feel helpless. They feel like, what else, how else? There are so many questions that arise as a result of this supposed inability to achieve an outcome. And can you see, it becomes very outcome focused. All the wording around getting pregnant and having a baby is very outcome focused. It's like either you're pregnant or you're not pregnant. And enjoyment, what's enjoyment in all of that?
Right. It's like you forgot about pleasure. Now I have a goal and I'm working.
That's exactly.
Literally.
I'm working to achieve this goal. Exactly.
And then after you have a baby, then that's also another problem, right? Oh, now we have no time. Now we're too stressed out. Now, so like, where is pleasure?
Tired.
Like, when does it come
Precisely.
in? When you're like 60. That's why a lot of older people are having great sex, and they're having a ton of sex in like senior living homes.
I was reading some statistics the other day talking about the fact that STIs are rampant in senior, like living situations. Because of that, they get to actually have sex and enjoy each other, and they've forgotten about any of the potential, problems and pitfalls of the whole experience, because no longer you need to worry about, am I going to get an STI because that's going to impact my fertility and it's going to make me, it's kind of like all of a sudden it's like it's a free-for-all, right?
Yeah.
But you see, and this is part of that whole conversation too, because often, prior to, a lot of people don't realize that, silent infections, sexually transmitted infections, can negatively impact one's fertility. But for the people who do realize, it's another factor that then we're starting to consider and having to take into account, that almost stops us from really being fully present in that moment. Because by the time you've got to think of all of these things that you've got to do to have the outcome that you are looking for in terms of experience, right? It's a lot of thinking and a lot of work, and the spontaneity of it all that does, come out of the situation somewhat. So when you ask me, what's the relationship? It's, for most people, it's almost non-existent, the relationship between pleasure and reproduction, which in my mind, really the reason that I started Talk Sex podcast was because I was so tired of hearing my patients say this sentence. I really want to get pregnant, but I don't want to have sex.
Oh God.
And I'm like, okay,
no.
well, so sure, we can do IVF and we can do all sorts of things, but there is an inherent problem with that idea, with that way of thinking, because like sex is such an important part of an experience of life.
Yeah.
Right?
And also, and like, if you don't want to have sex, are you with the right partner?
Yeah. And are you connecting with yourself?
Right.
In a way that actually, Absolutely, in a way that actually makes you feel whole and fulfilled,
Mm-hmm.
right? Because sex is not even just so, absolutely, are you with the right partner is the right question, but sex is an expression, right? It's an
Right.
ability for us to express ourselves. It's a way of self-care. It's a
Mm-hmm.
way of, finding ourselves at different levels
Mm-hmm.
of our own experience.
Mm-hmm.
And if you are so disconnected
Mm-hmm.
from yourself at that level, and that you don't want to experience those feelings and emotions and experiences at all, then we really have to ask, but how connected and how switched on are you really as a human,
Mm-hmm.
right?
What,
And
okay, so like in terms of, based on like science, pleasure isn't needed to conceive, right?
yes, absolutely, absolutely. But pleasure is needed to be a human.
Well said. Well said. I hope my Love Bites listeners know that, and I trust that they know that pleasure is something you choose and you got to choose it every day.
Yes,
And not just
yes.
sexual pleasure, all kinds of pleasures, right?
Absolutely,
So
absolutely. All kinds of pleasure. I think that's
you mentioned
beautiful.
something I found really interesting, and I want you to elaborate on that. You said have sex before you ovulate.
Mm.
What I've heard from most people, or like the internet, is you have sex when you ovulate. So what do you mean by before?
Yes, great question. And look, I think that it's important for us to do a little bit of biology 101 on this so that
Yes.
most people understand what I'm talking about here, but also understand that there are variations on this thing. For example, as I mentioned earlier, having been diagnosed with polycystic ovarian syndrome, which is the number one cause of infertility in women of the reproductive age,
Okay, can I
right?
stop you
15,
there? Can you talk about
yes.
PCOS first?
Yes, so basically polycystic ovarian syndrome is a condition where your regularity of ovulation is impacted or impeded. So irregular cycles is a key feature of the condition. It can be, metabolically speaking, there can be other systems that are, kind of at play.
Mhm.
Women with polycystic ovarian syndrome are more likely to have insulin resistance, diabetes, obesity. So there are lots of different other factors that can come into play. But one of the big things that happens for women with PCOS is that you don't ovulate regularly and you don't have regular periods. And sometimes you can have irregular periods that are just, cycles last 45 days instead of 28 days. Sometimes you can go 6 months without having a period. I had like a period of 2 years without
Wow.
having a period at all. And so the more that you don't have a period, the thicker the lining of the endometrium becomes, the more likelihood of cancers and, all sorts of things. So it's typically not of a major concern because eventually women with PCOS will bleed anyway. Lifestyle factors are incredibly beneficial in addressing the condition. I mean, I've had to, other than, exercise, eating well and a low glycemic index diet and, focusing on vegetables and protein and just avoiding sugars and, excess kind of refined carbohydrates, will definitely improve the symptoms that women experience. Another kind of, set of key features that women will typically experience if they have polycystic ovarian syndrome is acne and hirsutism, which is basically male pattern hair growth. So they might have excess hair on their face or, areola, belly button, so essentially more male pattern hair growth in terms of pubic hair and so on. And
So if you're
so,
just like a 20-year-old and you're wondering if you have PCOS, like are there actual like really clear
yes, there are
symptoms? Yeah.
guidelines in terms of diagnostics. So obviously the symptoms that I've just described will all be a part of the condition. And, if you go online and look at Rotterdam
Right.
diagnostic guidelines, so if you put diagnostic guidelines PCOS, there will be a list of symptoms that you will be able to see. Some of the symptoms and 3 things that you will actually potentially, for most women, and there are different categories of PCOS. Some women for example, will have follicles around the ovaries on ultrasound. So it's kind of like a rosary bead form on an ultrasound. That's one of the distinctive diagnostic pieces of PCOS, but some women don't have that and still have PCOS. So you might have irregular cycles, hirsutism, and say, you know, acne, and not have polycystic ovaries and still have PCOS, right? And, or you might have polycystic ovaries and acne and irregular cycles and have PCOS, or you might have an FSH to LH ratio. So in PCOS, the LH, luteinizing hormone, is typically 3 times higher than FSH for a positive diagnosis. AMH, which is anti-Müllerian hormone, will be highly elevated in women with PCOS. So it will be way above the normal range. So those are kind of like diagnostics in terms of blood tests and ultrasounds and things that women can do. But typically the symptoms have a huge role to play in the diagnosis of PCOS. When I was diagnosed, I had irregular cycles, I had hirsutism, and I had a little bit of acne, but I definitely did have polycystic ovaries. So on ultrasound. So that's how, and my LH to FSH ratio was elevated. So, you know, all of those pieces were like, that's what got the fateful call on that day, you know, to basically go polycystic ovarian disease. And I'm like, am I going to die? Actually, you know, that was the first question that I had. When he said that to me on the phone, I was like, am I going to die? Because, gosh, that sounds serious, right? But in going back to your question, in terms of, you know, how the cycle works and how the cycle operates and the deviations from the norm, that's really what we need to take into account. Women, there is normal variation that happens in a cycle, right? So women typically, you know, the textbook cycle length is 28 days or 29 and a half days. Actually, it's meant to go with the phases of the moon, interestingly. And so what happens is that for women who have different reasons or conditions that makes that lengthened, they still are having a pattern. It's that they don't recognize their pattern. And most women, without charting their cycle, won't recognize their patterns.
What about early period?
What do you mean by early periods?
Like more often. So like shorter days. Yeah. Like 20
cycles?
days, every 20 days. Yeah. Is that also a PCOS symptom?
That's not a PCOS symptom, but that is a sign of an infertile cycle. So if that's happening, typically it's caused by a luteal phase defect, right? And that's the shortening of the second half of this, because the follicular phase, which is the first half of the cycle, and then you have the ovulatory phase, which is, you know, the ovulation, and then you have the luteal phase. The follicular phase, the first half of the cycle, is typically the one that varies substantially from cycle to cycle, from women to women. So what happens with that is that if you have a shortened or lengthened cycle, for the most part, it is your follicular phase, the first half of your cycle, that's varying. So, and ovulation is going to be sooner or later as a result of that follicular phase varying. But the luteal phase, that, you know, typically is 14 days long, usually doesn't vary. But when it starts varying and it's less than 10 days, 11 days, for example, it means that the corpus luteum, which is the part that's left over after ovulation, that's meant to create progesterone to thicken the lining of the endometrium after ovulation for implantation of an embryo to occur, is not going to have developed or be big enough in order to be able to sustain the progesterone production that you need in the second half of the cycle through to 12 weeks, because it's meant to actually maintain that, you know, lining development up until 12 weeks, when then the placenta starts to take over that progesterone production for the keeping of the embryo in place. If you don't have, if your progesterone is low, what typically is going to happen, you're more likely to have implantation failure and miscarriage. So when your cycle is shortened, say for example, if you have a 20-day cycle, you haven't had enough estrogen progesterone to prepare that egg that is going to be fertilized to be as mature as it needs to be for implantation, for fertilization to occur, i.e. the sperm to get inside the egg, and then for fertilization the remaining, the corpus luteum kind of is left behind and starts to produce progesterone. But all of that is going to actually not have had enough time to mature and develop for that second half or that second phase to go on and continue. And so as a result, you might end up with difficulty in implantation occurring, placentation, and of course, keeping a pregnancy to term. So for some women, they may very well conceive, and this is what a lot of women that are quote unquote infertile don't realize, is that they're actually not infertile. They're just not keeping a pregnancy to term to a positive pregnancy test.
Right.
Fertilization may be occurring, i.e. the egg and the sperm might meet, but there isn't enough progesterone and things aren't actually continuing in the way that they should to get to a positive pregnancy test, but it's not that they're not conceiving, right? On the other hand of this, what is also important to understand and important to realize is that if you do experience a miscarriage, right, then you also need to understand that that's not to do just with one person, because a miscarriage is a 50-50 equation. It requires the sperm and the egg to occur, just as fertility is a 50-50 equation. I often talk about the fact that fertility is a team sport. And whatever fertility outcome you're experiencing as an end result. What you're demonstrating is an outcome, whether it's inability to conceive, inability to keep a pregnancy to term. All of these things are an end result of many biochemical chain reactions that precede that result in not one person, but two people.
Right. Lots of things have to happen.
Lots of things have to happen, right? And lots of things have to happen for both partners, because the standard fertility model these days takes the egg and goes, oh, we just need the sperm, and it's like the man is a sperm donor. It shouldn't be that way. Right. We really need to have a situation where both partners are understanding that fertility is a transgenerational outcome. What does that mean? You see, you today, in the package that you are in, Tara, you were actually already present in your grandmother's womb. I know it's like, whoa, brain, explosion here. But here's the thing. The reality is that your mother in your grandmother's womb already had you as an egg in her own womb. Women are born with all the eggs we'll ever have. So the exposures that your grandmother had in her lifetime will impact your fertility. It will certainly directly impact your mother's fertility, but it will impact your fertility as well.
Oh gosh. And so my mom was is a very stressed out woman.
Don't worry, because there are changes and there are things that you can do to moderate almost everything. But when people ask me, I want to get pregnant now, what should I do? Well, actually, that's a very, very deep question. It's not just a matter of eating healthfully and, de-stressing.
Taking vitamins.
It's not just about that. It's about that too. And those things are going to be important. But it's actually about so much more than that. We need to start looking at our exposures way before we decide that we want to have a baby. And that was one of the things that being diagnosed with PCOS very early on did for me, because it made me reconsider, it made me think about, okay, this may never happen, but if I want to give myself the best possible chance of having the choice for it to happen, how is it that I need to treat my body now? Right? And that was at 18 years of age. My first conception, I wanted to get pregnant at 32.
Right.
So there were many, many years in between that I had the opportunity and the choice to go, okay, I want to take care of my health and my body and my fertility for the long term. And this is really how we need to be looking at fertility, because not only fertility, as I said before, fertility is a team sport, but at any point in time, we need to be looking at fertility as an act pregnant now to get pregnant later type situation. So basically...
Like when I see, young 20 something, and I mean, me included in the past, like abusing their bodies through excessive partying and, whatever that comes with that, it makes me nervous about like all that's going to happen in the future in the body. Because we think we're invincible when we're so young.
Yes. And this is the thing. This is the thing we do. We think that we are invincible when we're young. The good news is that the body has an incredible ability to be able to regenerate. And we're going to talk about that too. But you see, the reality of it is that we need to start, wherever we stand, we need to start thinking about these processes in advance if we are wanting to optimize and prolong our fertility for as long as possible, right? That concept of acting pregnant now to get pregnant later applies throughout a woman's and a man's, by the way, entire reproductive life. Because, if you think about it, I often get asked, so what are the things that I should start doing or stop doing if I want to get pregnant? Well, it's really simple, right? And for the men listening to this conversation, indulge me for a moment and follow along with the thinking, because they need to do exactly the same thing that a woman would do. Right. So let's imagine for a moment that men could get pregnant and deliver babies. I know that the world population would decrease overnight if that was the case.
Yeah,
but
men
we
are
won't
like,
pick on the
fuck no, I won't get pregnant.
we won't pick on them too much, but just as a little side joke, if a man could get pregnant, and of course women know that we can get pregnant, for the most part. What are the things that if you were pregnant right this second, like what are the things that you would absolutely start doing and stop doing to protect and to ensure that you have the healthiest possible baby? So all of those things, whatever they are for you as an individual listening in, right? All of the things that you would absolutely start doing, stop doing, or inquire about if you were pregnant right this second, those are the things that you need to start doing, stop doing prior to pregnancy is in place. Because truthfully, what happens is that a baby's health blueprint is set for the rest of their life by 8 weeks gestation. You see, by 8 weeks gestation, a human already has all its little organs, all its little fingerprints, everything literally set in the womb. And from there, it just grows and develops. So the time to truly optimize a child's health isn't when you're pregnant. It's actually way before a pregnancy is even in place. And, for kind of the sake of understanding the maturation cycle of the egg and the sperm, one thing that women need to understand and realize is that we are born with all the eggs we'll ever have, which essentially means this: we are going to be developing and maturing eggs throughout our entire life cycle until menopause, of course. And what will happen is that those eggs don't all get released at the same time. They don't all get prepared at the same time. And so what happens with that is that it takes about two big stages of maturation for the egg to be ovulated. So from primordial follicle, which is the follicle that we are born with, to primary follicle, it takes about 5 to 6 months for that development to occur. Okay. Then from primary follicle to ovulatory follicle takes another 4 to 5 months. So really, we're talking about a maturation cycle for an oocyte, which is an egg that we are born with, of approximately 12 months. So absolutely, there is a lot you can do to optimize your health in that kind of second maturation cycle of 4 months, 4 to 5 months prior to ovulation. There's a whole heap that can be done. But really, to truly optimize egg quality and one's fertility, you want to be giving it the most amount of time that you can to reduce negative exposures and put in place the positive ones, the things that are going to enhance your health and enhance your fertility. Male fertility is slightly different. Men are creating and generating sperm all the time. A maturation cycle for a sperm is about 4 months. It's about 100 days. So let's say 4 months for the sake of the example. But when we have poor sperm parameters or poor sperm health, sometimes it can take 2 to 3 sperm cycles to really truly see a difference in sperm health. So that can almost match a woman's, female's oocyte maturation cycle in the length of time. And so that's what I was saying before. There are lots of things that people can do to improve and optimize their chances of conception, especially when things aren't necessarily going to plan. But what they need to be aware of is that the biochemical change time that it takes, it's approximately 6 months. So if you delay beginning making those improvements, say by 3 months, you're delaying results by 9 months.
Right.
If you delay making improvements by 6 months, you're delaying results by 12 months. And, you know, those delays in fertility window can be, you know, time can be quite problematic. So those are things that people need to understand. Now, I am quite aware that I haven't answered your question yet about timing.
Ooh,
And so
having sex 2 days or
that's right, ovulation. So
yeah. So
exactly.
what's that?
So this is now where we talk about timing. Now that we understand maturation cycles and all of these things, what we need to understand is that in a cycle, in a female reproductive cycle, which typically is 28 days, but, you know, sometimes, like I said, variation, follicular phase, luteal phase, and so on. What will happen there is that if you have a 28-day cycle, you are typically ovulating around day 14. But how do you know? Well, there's a few things that you can do to start to understand your cycle and what your body specifically is doing. These days, you know, there's apps, there's, you know, the Aura Ring, there's different things that you can do in terms of like tracking and, you know, all sorts of things that are going to, for me, temperature tracking is one of the best ways to truly understand what your body's doing. There are different devices you can wear. You can just, you know, take a thermometer and put it in your mouth. There's a couple of really great apps that you can actually keep track of your cycles. I'm more than happy to give you, if you want to put in the show notes later, I'm more than happy to give you some, you know, kind of tips and show you where I would, the things that I would recommend.
And then pee on a stick, right?
Well, you see, peeing on a stick, it gets really expensive, to be honest. You know, because those ovulation kits, they're not cheap. I mean, there are ones that you can buy that are reusable. And so if you're going to get one, that's probably what I would recommend. But those OPKs also aren't very, the predictability of them can be a little bit off.
Really?
The best way to really understand what's going on with your cycle is to chart your temperature and test your mucus changes throughout the month, your cervical mucus, because your cervical mucus is the thing that's going to actually tell you that ovulation is approaching. So how do you know when to start trying to conceive? Well, cervical mucus is the way that you actually test this. So when we have a period, obviously we have bleeding and, you know, there's a lot of moisture down there in the vaginal area, vulval area. After a period, you go about 2 or 3 days after a period and it's completely dry. There's very sticky, very dry. If there is any mucus in the opening of the vagina, it's going to be pretty dry, pretty sticky. You know, it's not very slippery at all. And then a couple of days will go past after that, and you will start to notice if you touch the mouth of the vagina, the opening of the vagina, you'll start to notice that there's a little bit of extra mucus, and it's a little bit thicker, it's a little bit tackier, but there is a bit more in comparison to how it was before, and it's relative to you. Right, it's relative to what you observe on you. So you are the N of 1 here. You are the trial. Right? And you're comparing it to yourself. So basically, a few days before ovulation, you start to get more mucus that's stretchier, but it's still like, you know, it's about a 5 centimeter kind of like stretch potential. And that's still not fertile mucus. But 1 to 2 days prior to ovulation, your mucus will become what I like to describe as egg white-like. It's literally so stretchy. It's called Spinnbarkeit. It's a German word, but it's literally so stretchy. You can actually take that stretchy egg white-like mucus and stretch it for 30 centimeters.
And this is something that women have to like touch their like vagina area and like pull it out, or?
No, you just literally do it at the mouth of the vagina. Typically, you know how when you go to the toilet, before you go to the toilet, sometimes you might have something on your underpants, like a little bit of mucus, a bit of wetness, a bit of water, you know, like watery kind of, you know, that's essentially what you're looking out for. In order to observe your mucus changes, you don't need to insert your fingers into your vagina. Some women do, but what you do want to check, you don't want to check it on toilet paper, because toilet paper will absorb all of the moisture. So what you need to do is before you go to the toilet to do a wee, you wash your hands, and before you go to do a wee, you actually touch the vulva and the opening of the vagina, just to see, okay, what kind of mucus do I have? How much do I have? And what kind of mucus do I have? So if you're tracking that for the day, the way that would look like is that you would literally, each time before you do a wee, you just check, it's just a quick little palpation. You just check and see, okay, what does this look like? Do I have more or less than before? And then in your app, you would actually mark the most profuse and greatest amount of that day. And what you will see is a trend of an upward trend to the amount and increased viscosity of that mucus prior to ovulation. And when you arrive at the point of 1 to 2 days prior to ovulation, where you will see there's
why you're saying people should have sex.
That's it. And really it's the time that you feel like you want to have sex the most anyway.
Right.
Right.
Why do other people say you have sex when you ovulate?
Okay, so first of all, people are saying that you have sex when you ovulate. It takes the sperm up to 3 days to get up to the fallopian tube where it's going to actually fertilize that egg, right? And so they say that, but it's not the correct thing, because what happens is that if you don't have sex 1 to 2 days prior to ovulation occurring, you won't have enough sperm. And it's, by the way, it doesn't mean that you have sex only 1 to 2 days prior to ovulation. You start your conception attempts 1 to 2 days prior, and you do it every second day until you have confirmed ovulation. So let's say if you start 1 to 2 days prior, you might have sex again the next day or 2 days later. That will still cover you for the next day in terms of conception attempts. And then you repeat that pattern until you know that you absolutely have ovulated. So how do you know that you've ovulated? Some women can tell as you start to track your symptoms throughout the month, you'll start to be able to notice, what it feels like before ovulation, during ovulation, after ovulation. Like for me, for example, what I notice is that most women, you start to feel engorgement of the lower, abdominal area, of the vulva, and all of those things. You start to feel sexier. Yeah. You start to feel more slippery. You start to feel like, oh, this is exciting and a bit, sexy down there, and you start to realize that, oh, okay, there's some changes going on. Now, for me personally, on the day of ovulation, I feel like I'm 9 months pregnant. I feel so bloated, and it's like not the day that I want to have sex at all. But 1 to 2 days before, it's like, bring it on, right? Okay. And this is just kind of like what you start to notice about yourself as you track. And that makes total sense biologically speaking, if you think about it, because what you want is to feel as horny and ready for having sex as possible before that egg drops, right? When the egg drops, it's almost like the body goes into a completely different mode. And it's just like, okay, you know what? I don't really want to have any more semen up this cavity because it's not going to help me with whatever it is that I'm trying to achieve. So for the woman to feel completely bloated, horrible, and decidedly unwanting of having any sex is actually biological genius, right?
It does feel like a lot tighter when, like, after ovulation.
Yeah. Everything changes. It's almost like, it's kind of your body's way of going, no go. The no-go zone has arrived, right? So, and then, of course, that starts to change as, the cycle proceeds from there.
Okay. So my last question is, what tips do you want to give for people to consider that are in their 20s, 30s, and 40s? We can start with 20s. What's like the 2 things they should consider?
Look, the interesting thing is that across the board, no matter what age group you're in, the first thing they need to do is act pregnant now to get pregnant later.
I like that.
So that's the one thing that you just absolutely want to do in general, because that takes care of exposures that you might be surrounded by that are not going to necessarily be in your best interest, and also to be able to add the exposures that are, for example, healthy diet, exercise, detoxification of your whole body. All of those pieces are the things that you want to add and subtract from your day-to-day across the board of all ages. Now, of course, in our 20s, we want to make sure that we're having safe sex. As boring as that might sound, silent infections play a huge role on whether a person is going to be as fertile as they can be later in their lifetime.
And that's like chlamydia, gonorrhea, HPV,
herpes, everything. I mean, you know, what's interesting, we conducted through my clinic, we conducted a meta-analysis recently on bacterial vaginosis associated bacteria and
BV.
sperm parameters. Yeah, BV. So we wanted to see whether there was an impact of, because obviously we know BV impacts female fertility.
Yeah.
And we wanted to see what was the impact of BV associated bacteria on sperm parameters. And there is a huge association of negative impact of BV associated bacteria and sperm parameters. So what does that mean? Well, you might think that, you know, you don't have any problems or any symptoms in terms of bacterial infections, bacteriospermia, or anything to do with, you know, you've never had an STI tested, or sorry, you've never had a positive STI result after testing, but it does not mean that you don't have bacteria in your genitourinary tract that is potentially negatively impacting your fertility as a woman and a man. Many of these infections, or, you know, bacterial load or even viral load that are found and sometimes not tested. I know that in the US, for example, herpes is very seldom tested because it's so prevalent in the population. So you may never have had symptoms, but you might still have the viruses, you know, and the bacteria kind of around in the reproductive system, in the reproductive tract. And that can still have an impact when it comes to the ability to conceive, the ability to keep a pregnancy to term. So things like that, you want to make sure that you are having properly screened. And sometimes you'll go to your doctor and you say, look, I want to get all of my STIs, all of the bacteria screened, and I want to have a culture. And they'll like do one thing, like chlamydia, gonorrhea, and syphilis, and go, oh yeah, you're all clear. But they haven't actually tested and done a proper culture and figured out that, you know, are you really all clear? So the best way to prevent an issue from arising later because of not knowing is to ensure that we're having help, you know, kind of safe sex, and obviously condoms and, you know, all that kind of stuff. So in terms of, and I think, look, you know, to be honest, that will be again across the entire life cycle, right? Of reproductive life cycle. So there isn't necessarily like a, you know, thing of like 20s, 30s, 40s, but what we do have to take into account is when we get to our mid to late 30s and 40s, that then we need to start looking at really specifically and almost aggressively understanding, you know, what are the obstacles if you've been trying to conceive for more, because you see in the general population, a couple at peak fertility has an average of 3 months time to pregnancy. So literally it's have sex, get pregnant, have a baby, done. We're no longer having this conversation. When that has not happened, then we need to start asking, okay, but what are the obstacles that are getting in the way? Why is this not happening? And understanding these obstacles very clearly, because one of the biggest reasons as to why couples remain infertile or experiencing recurrent miscarriage is because they don't know what they don't know. And the diagnosis of unexplained infertility or an unexplained recurrent miscarriage is really just poor as far as I'm concerned. You know, it's just not enough to be able to actually say to someone, oh, everything looks fine, just keep trying. It's like, well, I've been trying for 5 to 10 years and things aren't happening. And if it really was normal, we should not be having this conversation. So these are conversations clinically that I have literally on a daily basis with people, right? Because they've been trying to conceive for such a long time and they just keep being told, oh, everything's normal, just keep trying. And most couples who've run out of time to have a baby run out of time going around in circles. Again, because they don't know what they don't know. So very specific, appropriate diagnosis is one of the most important things that people can do. If they are trying, you know, for more than 3 to 6 months at any age, to start to question and figure out, okay, what do we need to do? And testing really needs to be done on both partners. You know, the number of people that come to my clinic that I treat who literally have been trying for like 5 years and the partner has not even had a semen analysis, it blows my mind.
Just the females, right?
Yeah. And
I think that's the natural reaction. Like, oh, so something's wrong with me.
which is really not how we look at this, right? Because
Mhm.
with any other partner, either of those people could have already conceived.
Mhm.
So we need to look at this from a perspective of, okay, we are wanting to create an outcome together. And if that outcome is not happening together, we need to figure out how can we actually optimize it. It's not about blaming one person or another, because the truth is, like I said, fertility is a team sport. So if it's not
Yes.
happening, it's a 50-50 equation, and we need to figure out why is that so that we're not in a situation where we go for months and years and then, you know, start to get an understanding at when we are already running out of time to have a baby. Right.
Yeah.
So this is a really important consideration. We've created in my clinic now, you know, we've collected a lot of data for many years, and we've done a study last year on our results and essentially what it is that we see with patients. And we can now, in 544 couples, 544 patients, we've demonstrated a 78.8% live birth rate for couples who were previously infertile for an average of 3.6 years.
Wow.
So, and that was our mean, right? And so, and our standard deviation was 4.3 years on top of that. So the reality of it is that there is so much that people can do, but if they don't know what it is that they need to do, because they don't know what's affecting them to begin with, it will never happen, you know? So this is the biggest thing that I think people need to really be aware of, is seeking diagnostic support, but really very, very, holistic diagnostic, not just the, you know, are the tubes clear? Do we have sperm? Because those questions, you know, are just not enough to be able to figure out what's going on if things aren't necessarily going to plan or are straightforward in the first
And a lot
instance.
of this is discussed in your book, right?
Oh yeah, 100%. So, you know, there's a, you know, it's almost like the tip of the iceberg though, because what's interesting about the discussion of diagnostics is that there are so many things. I mean, as you know, there are thousands of biochemical tests that you can run to understand how a person is, you know, how a person's body is working. And if we don't actually understand the person first and their context and what's going on for them, then we're, you know, it's almost like, you know, you can't just give everybody, okay, go and have these thousands of tests. And, you know, come back
like
to
that's
me.
not possible. So
it's not possible. So you really need to understand, okay, what is the context? What's the history? What's the context? What is it that we need to do? We're using a lot of artificial intelligence in our practice right now to be able to actually gather that understanding for couples much faster, and that's been very helpful for our patients. But, you know, really understanding the landscape of what's happening for a individual in a couple and that couple to get a result is crucial. And I think that that's the one thing that people need to really get more proactive about, is understanding their own situation sooner.
Totally. Yes. Learn about yourself, learn about your situation, definitely be active. And I love the saying, the acting
pregnant now to get pregnant
now
later.
to get pregnant later. Oh my gosh, I love it. Thank you so much, Gabriela. Before you go, I always play this game with my guests, and it's called 10 Quickies with Dr. Tara. And what it is I just give you a word and you give me your first response.
Oh goodness. All right, let's go.
Ready? Okay. Number 1, oral sex.
Delicious.
Number 2, sexual desire.
Oh, yes.
Number 3, happy sex life.
Begins with knowing yourself.
Number 4, secure attachment.
Cuddling.
Oh. Number 5, masturbation.
Oh, yes.
Number 6, squirting.
Oh, I like to know how to do that.
Number 7, vibrators.
I prefer my fingers.
Number 8, G-spot.
Is it real?
Number 9, intimacy.
Oh, wow. I drew a blank on that one. Intimacy. Desirable.
And last but not least, number 10, fertility.
It's a team sport.
It is a team sport. Thank you so much for your time today, Gabriela.
Thank you. Thank you so much for having me. Such a pleasure.
Yes. And never forget, right? Acting pregnant now to get pregnant later. I feel like that should
Yay.
be the title of this episode.
The mantra.
Yeah. Thank you so much. And thank you, my loves, for listening to this episode. I appreciate you and have an orgasmic day.
Thanks for listening. This was Love Bites. Love Bites. By Dr. Tara. Follow Dr. Tara on social media at lovebites.co. Have an orgasmic day.